Hello, hello, hello. First of all, a thank you to Annabelle's challenge, Jared, Jessica, everyone who's invited me to talk today. It's a real pleasure to get to address you. I'm just so sorry I can't be there today. I have childcare issues and a lack of forward planning, or just a conflict of dates. But even so, hopefully I've prepared a lot of information for you today that's accurate, relevant, and of some use. So my name's Jim Scott. That's me and the little blighters that I'm looking after today. My wife is sadly working. She works odd weekends, and this is one of them. I am a Sheffield dental graduate. I graduated back in 2007, and I quite like rugby. Running around the world, traveling, and that sort of stuff. So still very much in the Peter Pan phase of life. I commissioned into the British Army immediately, and have spent the last 15 years pottering around dirty, sandy, jungly places around the world. And a fair bit of the UK and Europe too. I had a really good time, but the Peter Pan has to stop at some point in time. So in 2020, I managed to get myself onto an academic clinical fellowship role in restorative dentistry back in Sheffield. And that's what brings me to you. So what is it? What am I? It does have relevance. So it's a sort of three-pronged approach to fill up a future professorial role. So they're training me over a 7-year pathway. Yes, I did sign up for that. A lot of my friends take the Michael out of me for it. But I'm trained in 4 areas of dentistry, which is really important for what we're going to talk about that today. And there are ways of doing sort of monospeciality where you just do one of these, but we get trained in all 4. And the advantage of that is then I can look at yourselves as patients, or the world as a researcher and a teacher in a more detailed way. So prosthetics is sticking teeth back in holes. Periodontics is gums. Endodontics is root fillings. And implantology is when you haven't got a tooth, screwing some metal into some bone, letting the bone physically, chemically bind to it, and then using that to support a tooth. And my current research is about you guys, and looking into a really obvious problem that I'm going to discuss at length today, but actually that not a lot is known about. And there's a lot of circumstantial evidence, but actually the real hardcore stuff that can lead to change in terms of policy to try and help the Ehlers-Danlos population isn't there yet. Give me some time. So let's talk a little bit about what we do know. And the stuff we do know is teeth. I know teeth really well. I've been cutting chunks out of teeth for the last 15 years in between my potterings. And on some of the potterings abroad, I've been doing teeth as well. And just so that we all understand each other a little bit here, I'm going to talk to you about teeth, and I love teeth. So hopefully you're going to love them too. So we're looking at the picture up ahead of us, the white stuff, and that's the stuff you can see all around your teeth on the outside. That is enamel. Now, enamel is mostly made up of something called calcium hydroxyapatite, which is like stone. It is rock hard. It doesn't have much ability to flex. And if it stays intact, it's really, really good stuff. When decay can get through it, it starts to be a bit of a problem. On the inside of that, you have something creamy, and that's the sort of yellow stuff that gives your teeth a different hue. So the enamel is actually very translucent. It sort of light shines straight through it, and it bounces off what's on the inside and comes back out. And the stuff on the inside is called dentine. Dentine is tubular, and it has little tubules that run from the nerve on the inside. That's the soft pulp that's highlighted up in front of you there. These little tubes run out, and then they're blocked off by the enamel. So dentine sensitivity, or the sensitivity you often sort of see on adverts or maybe suffer from yourselves, is where dentine is exposed, and then fluid can get pushed through these little tubules, and it kind of tugs at the nerves on the inside. And that's what dentine is in sensitivity. Now, dentine has a lot more collagen in it, and of course collagen is very important to the Ehlers-Danlos population. And then on the inside, you've got a nerve, and really it's like a vascular bundle to a point, but mostly it's made up of fairly randomly orientated collagen stuff. As people who spend their whole lives on it, I'm not so excited about the pulp bit, but it has got nerves in it and it's got blood vessels in it. And all of that is wrapped inside this dentine, and then the shell goes around the top, and your gums come up around the side, and they should come up to about where your enamel sits. You then have the roots of the teeth, and different teeth have different shaped roots, and they are supported in the bone by a really fine fur of ligament. And it's exactly the same ligament that sits in a muscle or at the end of a muscle, just like you'd see on the end of a chicken, but it's built into a fine fur. And that fur connects the bone to the tooth. All important stuff as we move forward. So what do we know? Next bit we know is Ehlers-Danlos. So we know that that's collagen not quite forming right. And how does that affect things? So we know that with vascular Ehlers-Danlos, this is mostly the malformation of type 3 collagen. So for you guys, actually, as dentine is formed, dentine has like a collagen matrix, and then it ossifies to a point. It kind of calcifies to a point. It's a very specific dental stuff, and that's pretty dull for anyone apart from me who loves it. But it's type 3 that really affects that. And then also then with the gingiva to a point, we've got a bit of type 3, and with the pulp, depends on the person, but again, type 3 collagen. The enamel on the outside, it's not really going to touch it, and to a point, the bone and the periodontal ligament, not so much again. Cementum's something I didn't mention there because it doesn't really affect you, but cementum's kind of like the rock for the furry stuff on the tooth side of your bone. So let's go to literature. That's what I love. It's what I think will make a big difference to you guys as a population. So if we look at stuff that's in medical journals and medical papers, we've got two areas. We've got quantitative, and this is stuff that we can count, and we've got qualitative. So quantitative is stuff that where you can get an absolute value for it. So if I look at me, I know that I am 193 centimeters, and that when I was younger, I was 196 centimeters, and having broken spines and femurs and legs and stuff, I've lost 3 centimeters, and I can measure that exactly. I know that because there's accurate records of my height when I was younger and now. Qualitative would be me feeling grumpy and how grumpy I am that I've lost 3 centimeters, and how incorrect it is that I'm the tallest man in the world with short man syndrome. And my feelings about that's the qualitative stuff. So quantitative stuff where it's been accurately counted by some scientists and then written up nicely, there are only 2 papers that really show this stuff. And they were written at a period of time when genetic confirmation wasn't absolute. So actually, particularly with the DaCosta paper, about half of the probands that he followed up were shown not to have the type of Ehlers-Danlos that they originally thought they did. And that kind of, in terms of setting up policies or moving things forward, that just drives a train through anything like that. But even so, that's what we've got to work on today. So they took 23 people, and I think DaCosta actually took about 50 people, and he matched them. So he took everything the same, so same height, age, sex, weight, apart from the only difference being that one person had Ehlers-Danlos of some description, and the others didn't, and he compared the 2 of them. And Farah was pretty similar as well. But as I said, clinical genetic diagnosis is a bit of an issue. What they found was change in pulp shape, so the internal architecture of teeth were slightly different, and that some teeth had slightly longer molar roots, and that would tend to be your back teeth, slightly longer, and therefore maybe a little bit more difficult to extract. They found no difference in dental decay, gum disease, and other stuff that other Ehlers-Danlos people find, where they get like little balls of dentine inside of their pulp, or in early tooth loss. I'll come on to it. You may be thinking, oh, that's not really what I've found. And I probably agree with you. With only 23 people across 2 papers, and the way that they investigated them, I think that actually that evidence, it's not worth the paper it's written on, but I don't think it's really going to bear true. So then the qualitative stuff. Sorry. So this is the stuff about how we feel. So questionnaires, and in dentistry we have something called the oral health impact profile, and this is a sort of standardized way of assessing how people feel about their oral health and their gums and their teeth. There are quite a few more papers on this because, as you can imagine, it's quite hard to get people to convince them to come and see you and have a checkup, and poke and prod them in the ways that we do as dentists. Whereas much easier to send them a questionnaire and hope that they might fill it in. So there's about 15 of these papers. Some of them are matched again in the same way, where they've taken matched groups of people, and some of them are not. But overall, there's well over 1,000 people with vascular Ehlers-Danlos who have answered these across the world. And that kind of helps out a little bit. And what's really clear from that is that vascular Ehlers-Danlos people have a lower OHIP score. So they're less happy with their teeth and their mouth. And that's really what OHIP shows. The problem with OHIP is that it shows really sort of broad trends. I'm fairly grumpy about this. I'm still very grumpy about being 3 centimeters shorter and not quite being 6'4". But at the same time, it doesn't tell me why I'm grumpy about that. You know, that's slightly the odd part of me. It shows some other things as well that were add-on questions, and some of that is the reduction in the efficacy of local anaesthetic to work in dental treatment. Now that's been shown to be very efficacious in other areas, and that is mostly around HEDS patients rather than BEDS or CEDS. And then of course that gums bleed a little bit more with the EDS. And that can lead to poor gum health. There's a bit of a chicken and an egg there, we don't know why, and hopefully at some point we might find that out. So I've been looking into this for about a year now, which means that a lot of people want to come and talk to me about it, and I love that. I really like meeting people. I like chatting to them. It's a pleasure. And from what I've found from patients and people who treat more Ehlers-Danlos patients, so I'm a restorative dentist, and that tends to mean that I get the really weird and complex stuff that no one else wants to deal with. But there are other specialities, and special care dentistry, they tend to get the stuff that people are scared of for, any dentist is scared of for medical reasons. So they see quite a few vascular Ehlers-Danlos patients, and the same with oral surgeons. And as you go around and people sort of hear that you're the Ehlers-Danlos dentist, people talk to you about this stuff. And I have heard of cases where there has been increased bleeding in and around the dental setting, both from cleaning of gums and from taking out of teeth. But actually, a lot of those guys have said, and these tend to be oral surgeons, so people are very good at dealing with bleeding from an oral environment, or indeed special care, who again, they're just used to dealing with people who don't clot the same, or people who it's harder to make stuff stop bleeding for other reasons. And they've mostly indicated that actually, because of the way that the bleeding in the mouth works, it can be stopped reasonably well. Now, I can guarantee that there are some people here who will be shaking their head and saying that didn't happen to me. And again, I really believe you. This is hearsay, really, and that's kind of where we're at the moment, because we don't have solid facts. But if you look at the way that bleeding occurs from an extraction, and that's why the little picture's up there. So that is the bone that's left, and you've got that periodontal ligament. Mostly it's minor vessels. And actually the way that we stop it is the body either forms a big chunk of clot that fills up the hole where the tooth was, or we put something in that hole that forms the formation for a clot, sort of forms scaffold for it, and then that clots, and then through the pressure from the clot, we stop bleeding. Actually, there's not a lot of big vessels, unless you're going somewhere else, that can be caught whilst we're working on this. As we're working with Glenda, we're really happy to support it, and we've got more people coming to us now at Sheffield, and we'll get more information and experience as we go forwards. Certainly, as we start setting up a service for anybody with Ehlers-Danlos in Sheffield, we're being belts and braces, so we're making sure that literally every eventuality that we think we might need is already there if we do take any teeth out, or indeed do any scales. Do these findings make sense? Yes and no. So I always think when you read a bit of literature, it's quite a good thing to do to then look back and sort of sit back a bit and say, okay, I can see what you've written there. Does this fit with the science behind it? And I come back to what we know about how stuff forms. So yes, dentine is likely to be a bit different because the scaffold that's originally there for it has an element of type 3 collagen that forms it. And again, the gums are likely to be a bit different. But I would expect them to be more different. And from the couple of patients I've seen so far, they have been more different. And coming back to that original literature that everything is based on at the moment, if you take 23 people and say half of them didn't have VEDS anyway, it's very hard to draw accurate conclusions. We have something called power in research where you have to have enough numbers of people to get an accurate representation. And I think that these studies were underpowered to be accurate in where we were going from that. So what are we going to do about that? Well, not all heroes wear capes. Oh no, my face is in Glenda's way. There's a lovely photo of Miss Sophie sitting underneath mine, which is a horrible thing to put on top of Glenda. But the two people above there, one is Ines Katfasibacher, a lovely, lovely Austrian lady. I've just been out with her in Innsbruck, and she could not have been more delightful to me. Thoroughly enjoyed my time with her. And the next one down is Professor Nick Martin, a very keen runner, a lovely, lovely guy who is head of the restorative department in Sheffield. And these three are guiding me in putting a reasonable piece of evidence together that will help answer the questions of how can we increase the OHIP? How can we make people happier with the Ehlers-Danlos community with their teeth? What are the problems that they're currently facing? What challenges is causing this? How are we doing this? So we've got some really good funding from the Ehlers-Danlos Society. And hopefully in the UK alone, we're going to bring in 70 vascular Ehlers-Danlos patients and 70 classic Ehlers-Danlos persons. And we're going to offer them the Rolls-Royce gold standard of objective assessment of their dental condition. So this is going to involve a 3D intraoral scan where we accurately take about 5.5 million photos of your teeth, which all gets put together and put into a 3D model. We're going to match that up with some radiographic findings. And then we're going to get really, really detailed with looking at the actual teeth themselves, how the gums sit. And in total, that'll last about an hour and a half. We're going to tie that in with some questionnaires that specifically talk about areas that have been found in the literature to cause problems for other Ehlers-Danlos persons. And see then if we can tie any of this up. See if what you tell us about what the problem is ties up with what we can see physically in the mouth. And hopefully the outcome from this will be that we can provide really accurate information to guide policy going forwards. Yes, we're going to write up papers and stuff, but from having had a chat with some of the Ehlers-Danlos Society persons and Jared actually, what I'd really like to produce, and the thing that I'm most excited about, is producing something really easy to digest that you can send to your dentist or your dental practice and say, hey, look, this here is what is going on with us, and this is what I need for you to be able to look after me a bit better. And the aim will always be to try and make it easy to access dental care. So being able to send this to your general dental practitioner, maybe with my email on it if they've got any big questions, so that they understand you more and exactly what is happening with you, or that they have at least the initial findings to go, okay, right, I can go and read about this more, and this is fairly easy for me to pull information from. I think would be really useful. And actually, that's what you guys have told me would be really useful. So, hey, let's go from that. That's us. Now, normally I'd be really keen and actually to have a beer with you guys tonight and find out more and listen to you talk to me would have been incredibly useful. But sadly, I will be wiping bottoms of two little toddlers. But if you do have any questions or any problems or any issues, hopefully I've not dug myself any holes today. very much unlike this excellent hole I dug in North Norfolk a couple of weekends ago while I was camping with the little ones. But if you do have any questions, please take this down and email me. I'm always really keen to hear, speak, chat. An absolute pleasure. So hopefully I've not bored you with teeth. They're ace. And I shall look forward to hearing from you, or maybe even if you were interested in coming over to Sheffield to have us have a really good look at your teeth. I might see you come September, October time. Look, guys, thanks for your time. Really nice. Bye.